Welcome to Countermeasures. I'm Rebecca Costa, and thank you for joining me for another hour of live, uncensored, unbiased news. Every week we deconstruct today's most difficult issues in order to get to the bottom of what's really going on. Our guest on today's program is Dr. Brian McGowan, who believes that your zip code plays an important role in your prospects for living a long life. According to McGowan, a 10-mile difference between where you live can have a dramatic difference in the quality of care you receive in the United States. And he's not only going to reveal some startling statistics along those lines, but also tell us what we can do to make sure we get the highest quality of care possible. But before Dr. McGowan joins us in the studio, let's say hello to our chat czar Meredith, who's going to tell you how to log in and submit your questions for our guest today. Good morning, Meredith.
Good morning, Rebecca. If you've seen our show, you know that you as the viewers have the opportunity to participate and join the conversation as it's happening live. So go on Twitter and tweet your questions using our hashtag, which is #CMWRC, or you can email us at countermeasures@emPOWERme.tv.
Thanks, Meredith, and we'll check back with you a little later in the program. This week, as any hope of a jobs bill being passed continued to be dashed by partisan politics, and increasing numbers of citizens joined the Occupy Wall Street movement, Citigroup reported a 74% jump in quarterly profits, its seventh straight quarter of profitability. Bank of America also reported $6.2 billion in third quarter profits, along with Wells Fargo, whose profits rose 21%, and Morgan Stanley, who reported $3.8 billion in profits. Which begs the question, if America's financial institutions are faring so well, why isn't the economy getting better? After all, it wasn't that long ago, 2008 to be exact, that these same financial institutions were on the verge of going under and needed to be bailed out by the federal government. So what happened in such a short period of time to allow banks to post quarterly profits in the billions? Well, I'm going to tell you. Big lending institutions are at it again. They're making high-interest loans to borrowers who have no ability to pay those loans back. Only this time, it isn't home loans. But more about that in our bad policy of the week. The bad policy of the week is a warning to our nation's leaders. The next subprime fiasco is on its way, only this time it will be more frightening and widespread than the collapse of the housing market. Financial institutions are issuing credit cards to unqualified individuals in record numbers. The latest reports indicate there are 800 million credit cards in use in the United States, more than 2 cards for every man, woman, and baby. What's more, not long ago, Premier Bank Card in South Dakota raised their interest rates on credit cards to almost 80%. Let me say that again, 80%. Of course, in compliance with the Credit Card Reform Act, they notified cardholders that they had 60 days to pay their debt before the new interest rates kicked in. But the people who have been hardest hit by the economy had no way to pay that debt in 60 days. In other words, they were trapped. What's more, as you watch this program today, college dormitories at every university are being stuffed with credit card applications offering students with no jobs and no assets $5,000 to $10,000 in credit. Today, 74% of all college students carry credit card balances from month to month. It isn't low-interest student loans that they should be frightened of. It's credit card debt, which they pay 29% interest on. What's even more worrisome is that credit card loans are being packaged up as derivative-style investments on Wall Street, just like the subprime mortgages which caused the housing collapse. And with very few places where individuals can get decent returns on their money, these derivatives are being bought, sold, and rising in value, just like the subprime loans that triggered the current worldwide recession. If you're wondering why the real estate market hasn't recovered, that's easy. Banks aren't making home loans. Why would any business make a home loan at 4% when you can get a credit card loan for 80%? In the final analysis, The economy can't recover unless people can borrow money to buy goods. So as the economy falls further into trouble and people have fewer financial options, the offer of credit, even at interest rates of 80%, isn't something the person on the street is going to turn down. Our bad policy this week is a warning to our leaders that they have once again fallen asleep at the wheel. Financial institutions earned over $50 billion from credit card lending last year, and this number is skyrocketing. In the meanwhile, miss one payment on a single card and the banks are permitted to raise interest rates on all your cards across the board. Elected leaders need to act quickly to get on top of the predatory credit card practices, which are now putting students, the unemployed, and the middle class into a hole that grows deeper by the minute. And if there is one thing we should have learned from the damage that lending to unqualified borrowers caused the economy, it is the record defaults, the number of defaults that will lead to the collapse of derivatives once again. Unless credit card interest rates are brought in line with small business and home mortgage loans, there is simply no incentive for banks to make the kind of loans that will stimulate jobs and help the economy get back on its feet again. And that's our bad policy of the week. Next up, Dr. Brian McGowan will be joining me right here in the studio to discuss a common sense approach to health care called the social QI model. That story next.
If you haven't picked up a copy of The Watchman's Rattle yet, may I make a suggestion? First, read what the experts have to say about the book. Go to www.rebeccacosta.com, where you'll find reviews written by game changers such as Sir Richard Branson, Trudy Styler, Tina Brown, Donald Trump, Senator Bill Bradley, and two-time Pulitzer Prize winner Dr. Edward O. Wilson. The Watchman's Rattle was recently named the top science book of 2010 by the American Library Journal. Over 50 reviews and articles from experts at the New York Times, Inc. magazine, CNN's Larry King Live, the Huffington Post, and the San Jose Mercury News are also available on the website. If you haven't picked up your copy of The Watchman's Rattle, a page-turner that spells out why governments, experts, and leaders have become gridlocked and can no longer solve our most dangerous problems, don't wait. Read what the critics have to say. Order your first edition copy today. Available at bookstores everywhere and Amazon.com.
I'm here in the studio today with Dr. Brian McGowan, who is an expert at cardiovascular physiology. He's been part of the heart transplant teams at I keep wanting to say Temple University Hospital. Is that right?
That
Do
is
I have
correct.
that right?
Absolutely.
Okay. And he's participated in over 500 heart transplants and LVAD placements. He's currently working with Pfizer Corporation in order to educate physicians on emerging treatments. And it's such an honor to have him in the studio today. Thank you for being with us.
Thank you for having me.
Let me just start with the 30,000-foot level problem. In this country today, we spend one of the highest percentages of GDP on health care. And yet consistently, and it doesn't matter which study you look at, we come in at kind of a low ranking in terms of the quality of health care that's delivered. Now, you make the point that when we look at that quality, we're sort of acting as though it's a uniformly low quality of healthcare delivery. But you make the point that there are pockets where we have the highest levels in the world in terms of healthcare and areas where we have the lowest levels, and that there's a lack of uniformity. So it's kind of erroneous to say, well, we have the lowest quality, because it's as though it's low everywhere. So I'd like you to sort of talk about that and explain that to us.
It's a great question. So the quality can be deconstructed. So to say quality in healthcare, the way that the Institute of Medicine defines quality is safety, the timeliness, how efficient, how effective, how equitable, and how patient-centered it is. It's those 6 factors make up quality. So as you were saying, we're heterogeneous. We're actually pretty poor as a U.S. healthcare system in the equitability of the care that we provide. We're pretty low in the efficiency of the care we provide, but we're pretty good in the effectiveness of the care we provide. And that has more to do with the Cleveland Clinic, Mayo, Kaiser Permanente systems, the bastions of high quality care. So across the continuum, if you're on the south side of Chicago versus the north side of Chicago, your readmission rates for heart failure, for instance, could be twice as high. You're 10 miles apart.
Now, what's driving that? I mean, you've got hospitals 10 miles apart, and you've got twice the readmission rates in one hospital as another. Now, we know that there aren't people that are twice as sick 10 miles away.
Right.
I mean, it's not likely.
No, in fact, if you take out the confounder, so 53-year-old black man, you normalize for all of that, it's the zip code, it's the healthcare system or the access that they have to care. So it could be on the preventative side. It could be that people get into the system more quickly on one side of the system than they do on the other side of the system, so they've progressed further in their disease state before they're seen. It could just be the access to care. It could be the fact that the system's competitive, right? So the systems on the north side want their billboard to say we're the #1 heart failure system in the region. So if they're finding best practices, those best practices are never being shared with the systems on the south side of this. So your zip code, as important maybe as your risk factors, as important as your genetics, but it's either an access thing, which we can solve with one set of solutions, or it's a competitive thing, which we have to solve with a different set of solutions.
Now, this sounds really fragmented.
Yeah.
It sounds like the doctors, the hospitals, the insurance agencies, the people that are developing technologies like pharmaceutical or medical devices, it's just fragmented all over the place. How did we get to that state, and what can we do to get healthcare to be marching to the same drum?
Your term from the book is the super siloing of a profession. So the complexity of the information that directs medical care, it's so complex that we've ended up moving towards these areas of specialization. So you're specializing, even in medical practice, you're specializing in cardiology. Now you're specializing in interventional radiology, cardiology. Now
and it keeps getting sliced down into thinner and thinner areas of specialization. But the connective tissue needed between these areas of specialization. I happen to know, because I shared with you, my mother was diagnosed with cancer, and that was my first direct interface with the healthcare system, because we happen to be a healthy family, you know, outside of preventative things like regular checkups. We didn't really have that much to do with the healthcare system. Once we got into it, it wasn't just an oncologist, it was a radiation oncologist and a surgeon and a, you know, and thankfully, we were able to find our way to a panel of specialists who had convened and would give their joint diagnosis and prescription as to what to do. But how many people would have gone through the steps that we went through? It's got to be a small percentage that find their way to one of these panels and the best care that we could have gotten for my mother.
I think it's a very small percentage, and no one practices being a patient, right? So here you are, the first time you're trying to navigate the system, and there's emergent issues going on with your health or your loved one's health.
And the stakes are high, and you're being dropped in as a, you know, you're parachuted into an environment you know nothing about.
So for 70 years, medicine's been about the hierarchy, the authority of the medicine. So you're parachuted in. At least now you have one single authoritarian person who can direct your care, and you trust that person. That's the hallmarks of 20th century medicine. And that's what got us to this place of kind of a broken and fragmented system, that we have experts in different areas. Those experts rarely ever communicate with one another.
How do they communicate with, how do they share information today?
If they're in the same specialty, so cardiology, then they meet 2 or 3 times a year at annual meetings or subsets of annual meetings, in Chicago at the American Heart Association or in Atlanta at the American College of Cardiology. And they bump into one another amongst 20,000 people at the meeting.
This is not making me feel good. This is sounding like it's sort of a random, they're running into each other, they call a colleague if they have a problem they can't solve. I mean,
the flip side is, they're so entrenched in the system that they're one of the 3 or 4 people that kind of control that area of research scientists. So they're the leaders, the truest thought leaders, and they're connected to everybody. But now they have a territory to protect, right? So you either have the 1% of the physicians in a specialty that are super connected, but it's so connected that it becomes too close-knit, or you have the 97% of physicians in that specialty that are more community-based. They're less connected to a system. They have their tribes, to steal another term from the book. They're based on geography. So who are the 15 other docs like them in their area? Maybe they can bump into those folks a little bit more frequently. The lore of the golf course physician. That's where it came from. Is
A lot of that communication goes on outside the office. As you say, you know, they walk into the hall and ask for whoever's standing in the hall, what their opinions are. I want to take a moment to go over to the chat room because I can see we have a lot of activity going on. Meredith, what do you have for us?
There seem to be some questions as to whether doctors are using social media, and if so, is it being accepted in your medical community, or is there some resistance?
Yeah, what about technology? I mean, how does that play into doctors communicating with each other, sharing information?
I don't know if it's going to be the silver bullet, at least the way it's engineered now. It doesn't appear to be the silver bullet. Actually, I just conducted and presented some research at Stanford a few weeks ago on specifically how physicians are using these technologies to learn, because you can use them for a lot of reasons. Facebook, LinkedIn, Twitter weren't invented for physicians. They're invented for other people, so physicians are adopting them for other uses.
Are they using social media to communicate?
The adoption curve is behind the general population. 6% of physicians are using Twitter as a means of interprofessional conversation, lifelong learning. 14% are using LinkedIn. But where we do find physicians learning, and maybe even a majority of physicians, if you include 51% as the majority, it looks like 51% of physicians are engaging in online communities. Sermo being one, Osmosis, MedTrust Online, but also within their medical societies. So, for example, the American Academy of Family Practice has a program called the Patient-Centered Medical Home Initiative. And in that, they build a registry. So if this panel that you were discussing with your mother, patient-centered medical homes are similar to that, except it's at the origin of disease. So your preventative care, your primary care, can be presented in more of a panel-like approach. Your primary care doc can direct you through all the preventative measures you need.
Where you can get a number of specialists weighing in at the same time.
In an effective and an efficient and an equitable way, right, to meet those quality definitions.
And are there ways that they monitor the quality of the information that's coming over the internet? Because, I mean, you don't know who that person is on the other end. You don't know how qualified that panel might be. So how does that happen?
There are certainly skills that have to be developed over time. I think the first one is the signal-to-noise ratio. If you're using these open-source social media technologies, then you can see hundreds, if not even thousands, of different messages coming at you like drinking from a fire hose.
You bet.
And if you can't figure out a way to wade through that, that's important. I think the credibility issues may be the #1 barrier right now.
Volume, credibility and volume, as we talk about it, it's so complex. It's even complex for the doctors who are specialists to weed through that. So a layman like myself who gets parachuted into that situation, and it's time sensitive. You've got somebody who's ill who needs care right away. How do you become an expert to navigate through that medical system? We've got another question coming in through the chat room here.
First of all, thanks, Racket, for the last question. This question's by Elizabeth. To your point, how do you know who's credible online? How can a consumer know?
Well, that's a tough question.
$1 million question.
I tell you, the people that watch this program, they're smart, and you know they don't throw you any softballs.
No, I appreciate that, Elizabeth. I think ultimately the skills that we've developed in interpersonal communication, we need to evolve slightly different skills in interpersonal virtual communication. First off, if you're engaged in medical communication, whether you're a patient talking to a physician or a physician talking to a physician, anonymity is a crucially sensitive element in this. There are times where your privacy can only be provided through true anonymity. So we have to develop systems that allow for anonymity and privacy to thrive. There are other times, like interprofessional conversation, where anonymity, it's tough to connect anonymity and professionalism. So that's one issue. If you're dealing in an environment where people are gunslinger 52, and that's who you're interacting
Right,
with
right.
online, that certainly decreases one's credibility. But the last thing I'd say is, over time, just like on StubHub or eBay, the community should be able to vote up someone's credibility. You should be able to establish a reputation within whatever community you're dealing with, even something as high stakes as medicine. You should be able to establish your reputation within that community over time with good participation and with quality contributions.
Well, it's interesting, like everything else on the internet, you implement a variety of tests. The first time you order from an online site you've never ordered on, I always think, well, maybe I'll get my goods and maybe I won't. Maybe I just sent my money or my credit card information to somebody.
I got this backup high-interest credit card that I use just for that.
Right, and so, you're always testing, and I think what you're saying is that, those doctors or those panels that are giving very, very good medical advice would be by word of mouth even, would eventually rise up to higher higher up in the hierarchy. But you also talk about something called the social QI.
Right.
So let's talk about that social QI, because I think you have a book coming out next fall. I mean, it's a year away, so we can't exactly promote it, but I wish I could get, can I get my hands on an early copy?
As soon as it's in print, as soon as there's enough words on the paper, you'll be the first.
Okay, because I want to be an expert before I have to actually re-enter the healthcare system again. So talk to us about the social QI. What does it mean?
So you have this community of patients, and even before patients, they're just humans. They engage in preventative measures. They're on Facebook. They're connected. I think we can leverage the patient and wellness community by building a structure that allows them to share their own health information.
What would that be like? Like, give us an example.
There are hundreds and thousands of examples of ways it's being used through Facebook or through Twitter. My daughter, this is a story that was recently shared with me, a daughter with a sensory defect. It took 6 years for that sensory defect to be diagnosed by her pediatrician. She actually found the answer through her social network. Right? So if that social network was engineered in a way to make those conversations more efficient, it wouldn't have taken 6 years before she found the one person whose daughter had those same symptoms themselves.
So she was describing her symptoms
to friends and
to
family
friends on
and
Facebook, Twitter, and
Yep.
all of that, and then somehow she connected with
Finally
somebody
found
who
one
said,
person.
"I know what that is."
Another case last week,
I see.
or a few months ago actually, of a mother who took a picture of a rash. There few people said, be careful, it looks like a bad skin rash. Come back a week later, the rash has gotten worse, takes another picture, it finally goes to the ER. ER sends the mother home. She comes back distraught, sends a picture the next morning, her child's face is all swollen. Finally, a family member said, you have to go to the ER now. Basically, at this point, every hour is defects that the child's internal organs won't be able to overcome. And it found out that the child was suffering from Kawasaki's disease. And the only reason it happened was because this mother got progressively distraught. The images and her outcry on Facebook got progressively louder and more severe. And finally, a family member, after 3 or 4 or 5 times seeing this, finally was engaged enough that someone found an answer for her. I think in that patient and wellness community, we should be able to do something a little bit more effective than serendipity.
So you'd like to capture the wisdom of that.
Collective
The
intelligence.
collective intelligence, what Edward Wilson many years ago wrote a book called Consilience, the Unity of Knowledge. And I think that's what you're really talking about, is we have this knowledge and it's out there in the stratosphere. We now have this technology called social media.
Makes it a lot easier to share.
Right, so now we have the actual mechanism by which we can make this sharing possible. And a mother who has a rash on a child and is worried about it and keeps going back to the hospital and getting sent home can now send that out, and then someone can connect the dots for that parent. And now, why do you call that the social QI?
Because in medicine, QI, or quality improvement, is a large push. It's actually being tied into the way physicians are licensed and their certification. So quality improvement is about improving those 6 things: the safety, timeliness, equity, efficiency, effectiveness, and the patient-centeredness of care. If we can employer leverage social technology, a social learning culture, the sharing of information and knowledge to impact quality, I think there's an entirely different approach to the problem. Instead of everyone trying their own solution, trial and error, small case studies, small pilots, small mitigations, that maybe there's an approach where we can use these learning technologies to have a systemic mitigation.
We have some more viewers that, you know, they're sending lots of questions in, and one of the tragedies of having a 1-hour program is I can't get to all the questions. So afterwards, I do encourage people to send me their questions to www.rebeccacosta.com, and I will get them to Dr. McGowan, and we will get you answers. So Meredith, what do you have for us?
We have a question from Modern. What is the concern over whether physicians will participate in social learning or not?
Well, right now, probably the area of this science, this social engagement science that we know the least about, is what the barriers to adoption are. It's why I'm very specifically focused on learning. If you say use social media to treat patients, talk about high stakes, HIPAA issues, privacy, liability issues, everything comes front and center when you're using an open channel of communication to discuss a patient's sickness or a patient care issue over those channels. If you focus specifically on interprofessional learning and medical information sharing, what are you doing with the latest billing codes? How are you moving patients through your practice? These are business practice things. It's a little bit easier, less risky to share. If you use these channels and you don't identify what the use is, so I talked to you about social media, I think most people, when they think about physicians using social media, immediately identify with the patient care side, what I call bucket one use.
Sure.
And the risks are so high that the interest in adopting those technologies becomes really, really muted. Right? So if you're looking at this as all you think about is the risks associated with treating patients through Facebook, then you are discounting everything positive that could possibly come out of other forms of social media. But I don't think beyond that, that's just my belief, I don't think beyond that we really understand the barriers to adoption. I've done this a few times where I've just sent out a tweet asking the community, the healthcare social media, what we call the HICSM community, why do you think doctors don't use this? And it takes too much time. I've got better things to do. I'm not incentivized for it. It's too risky. So these are the issues. If I apply those reasons to lifelong learning, none of them, except maybe time, really apply to that use. Those barriers all apply to that high-risk patient engagement use.
But it seems like it would make infinite sense if I could just Facebook or tweet my doctor some general symptoms and find out if I should even go in. I mean, I think you could weed out 30% of people that are just paranoid and go in to see their doctor. And as I get older, I don't know if, you know, that ache and pain is just because I lifted a case of water at Costco, or I really that really means something and I ought to get in there. So
doesn't it make a lot of sense?
It just seems like you'd just be able to, you know, get rid of some of the load as saying, look, that's not a problem, or go get an over-the-counter lotion to get rid of that rash that looks like poison oak. I mean, a lot of these things I think you could deal ideally on the internet with.
I think there's a few cases of this bucket one use where you're doing that, where you're engaging. Jen Dyer, who's an endocrinologist, pediatric endocrinologist, would tell a story about how when her patients aged adolescent and eventually went off to college, she did have relationships with enough of her patients that she would be able to post on their Facebook page, you know, it's Saturday morning, hope last night went well, how's your blood sugar? Okay, so, well, that was a patient with type 1 diabetes who had kind of lived this life for a long time, and there was consent between the two adults to do that.
And they were able to maintain a relationship at a distance, even after the person left.
With so much less complexity of an office visit or documented this. But there's other cases. Wendy Swanson, who works out in Seattle, she tells these stories of she wishes, she'll wake up in the middle of the night concerned about a patient she saw that day. And she wishes she could just send that patient a text message.
Right, just a short communication. Is there an issue about liability? When you talk about connective tissue, you talk about patients putting a rash, right, out over Facebook and saying, look, my daughter's had this rash, it's getting worse and worse. Is there a liability there where suddenly that mother can say, look, I went to the hospital 3 times, it's now recorded on Facebook that my daughter was getting worse and worse? I mean, do you feel that that might be some resistance?
So risky. It's that area of this adoption of the social QI model where you're focused on specifically on patient care is so risky, I'm not sure, and so complex. It doesn't seem like it's the appropriate way to start. In my mind, if you can get peer-to-peer health as a platform where patients can share with one another, then that builds up a culture of social, medical, peer-to-peer health management in the patient community. If you can do the same things with physicians, sharing best practices, extending beyond their geography or their pedigree, and sharing with a new community of like-minded scientists, or even biomedical researchers and development folks who are studying animal models and cell culture lines, if they can share.
And they may be able to weigh in on some of these things, whereas right now, as you point out, those folks that are biomedical researchers are not necessarily talking to the doctors that are treating people, who are not necessarily talking to the patients that are outside of their 10-mile radius.
And whether they're
right?
talking
Right?
or even listening to. It's one thing to say, are you going to go the extra step to actually answer questions and interact? It's another thing to be able to build up a personal learning network where you're tracking all of this information and just listening to it. Right? That's in fact most of the connections that I've made that are helping me write the book are crowdsourced. My tweet deck and my connections through LinkedIn and Google Plus are basically informing almost every interview I need to do for this book. Dr. Brian Vardabadian from Baylor.
You have to be careful about that because, you know, I experienced the same thing, and then over a period of time, I kept learning and learning and learning, and there was no point at which I felt I could write the book because I knew that somebody was going to send me 10 more studies next week, and you know, everything I wrote would be incomplete. So at some point, you got to draw the line.
So I've sketched it out enough, and I've told the editor many times, your job is to stop me from writing a 1,000-page book. I want to write a 250.
It'll be 10,000 pages, but that's what you have editors for.
Absolutely.
All right, I want to go back to the chat room. Meredith, you have some questions for us?
Yes, we have an email question in from Adam. What's the incentive for doctors to treat over social media? Is it billable?
So notice that the questions tend to focus on treating over social media.
They
and
do.
If I've learned anything in 2.5 years,
Yeah.
every time you have this discussion, the way the physician-patient interface is just so front and center of our culture that that's where everyone's mind goes. So I'll answer Adam's questions. It's currently not billable, but there are some movements afoot to kind of take the connection from telemedicine, which in some cases is billable, to take the advances from rural medicine practice, which uses telemedicine quite frequently, and to explore that in social media. But the limitation would be the infrastructure by which you're offering your care through social media. Through Twitter, it's tough to do the documentation that would be required to make that billable. But if your office had a closed system that had a social media component where you could log on to my website or even my app for Dr. Bob's pediatric care, and you could look, then you should be able to take a picture, snap it, send it to Dr. Bob. It's actually all now integrated into the electronic health record. And it's a great segue because I think that's the ultimate solution. When we move away from Facebook and Twitter and LinkedIn, and we build an infrastructure of social technology infrastructure that's now integrated into what physicians do, when it's on their screen right next to their EMR, right next to IBM Watson version where it's doing a little background check for physicians. If we make social learning...
How would that look? Like, give me an example. I'm on a screen, I'm a physician, and I'm looking at my patient's records or information that's come in from my patient.
Sure, and in the perfect system, there's a webcam on the back of the laptop too, because you'd like some eye contact with the patient, and that seems to be a major problem. You don't want physicians staring at the computer screen. You don't want technology to separate the physician from the patient. It's too crucial of an interaction. But increasingly, physicians are using EMR to drive medical safety. So there's probably 50 or more EMR, electronic medical records companies that are coming out right now that each have different software applications. But ultimately it's an interface where you can type in body weight, you can type in questions that were asked, you can type in consultation. if the keystrokes that I type into the EMR would immediately lead into a search of the world's medical database to bring up information that I may not be familiar with or may be so late breaking, the publication just came out last week, I think that's the natural progression. So
this is
EMR,
like a search engine that has artificial intelligence, and it's basically looking at certain parameters and then saying, by the way, here's some breaking studies that seem to tie into what you're exactly doing your search on. Is that
right now, 50 to 60% of physicians admit to going on Google or even going on Wikipedia to look up medical information.
But there's nothing specifically designed for them. This is the generic Google tools that they're using.
And we're losing all that effort. So the doctor just asked a really pertinent question on a Google search bar. It's saved to their browser, but what other physician who had the same question could have learned from the way that the answer was found?
Well, you know, I had this experience. I had some temporary hearing loss, and I walked into a doctor, and he turned around and he said, well, tell me about it again, and I explained it to him, and he got on Google. I saw he was using Google search engines, and I thought, is that all you have? I could have done that at home.
So the adage is that medical students were told to never open a book in front of a patient. That a physician...
Oh, they're definitely using their computers
now
right there while you're sitting in their
Now they're
office.
being told to put everything's on the app. It's on their iPad. So that technology is getting into the exam room. What we have to be really critically careful of is that the technology supports the medical visit. It doesn't interfere in the medical visit. And that's, I think, where we're getting a little bit off center right now. I think many of the technologies that are being built to solve one single problem in healthcare: track your sleeping pattern, track your steps through a pedometer. We're tracking all this stuff. But then that's just more information. We've talked about this.
We talked about this. If you have a billion possible solutions, it's the same as having none.
Right.
The human brain can't deal with that and can't sort through it and can't prioritize it.
Even the human physician brain can't do it.
And that's what doctors are really dealing with right now. I mean, I think it is incredible because as global communications has become very, very easy, you have all these studies and research and things coming from all different sources, and you don't even have a way to know which are valid studies unless you read the whole thing and analyze whether the study was actually valid.
But you could almost at this point ask the same question about the peer review and publication process. In the last 3 or 4 years, that's been flipped on its head. If you publish an article and 12 months later it's finally released, but it was peer reviewed by 3 people who you don't know, and the entire rules of peer review prohibit you from knowing who they are, right? Or would you rather it peer reviewed by 100 colleagues and engage in a conversation about it? A crowdsourced peer review? Maybe the time's come. So I think there's a few people that are trying to figure out, that's that third community, the biomedical
Right, so we have
research
doctors that are overwhelmed with data, right? And it's not just the volume of data, it's the credibility of the data.
and the complexity, yeah.
And the complexity of it, because sometimes these studies are you know, they're not exactly well written. May I say that?
You may. You may.
Because you know, I have to do a lot of research for the kinds of books that I write, and some of these studies, I'm reading the same page over and over again because they're not easy to understand.
The better part of 3 years of my doctorate to understand how to read a research article, but more importantly, to have a knowledge base that's broad and deep enough that I understood the context behind the research article.
And how about the translated research?
Yeah.
We can't even go there.
There's enough
it's
space.
It's difficult. So what you're proposing is that doctors begin, instead of seeing each other in hospitals and insurance companies and everything, instead of dealing with things episodically, instead of competing, instead of defending territories or patients or anything, they've got to start getting together and they've got to start sharing information purely to survive, because if they don't do that, they're really opening up the door to liability, aren't they?
Yeah, I think there's survival.
I mean, isn't there an inverse relationship here between complexity and growing liability?
I hesitate to get into tort reform discussions, but I think the survival in 2 ways. The more they share, the more survival there is for their patients. I think the quality goes up, but I also think there's more professional survival in it for them. I think it extends their network, and what we'll find, I think, over the next 10 years is that the network that you that you operate in professionally is going to be as important as the pedigree of where you trained or the community in which you serve. It's great to say.
Now I'm going to put you on the spot. You get out there, and I know you do a lot of talks, and you're a popular fellow. So what is their reaction? Do they embrace what you're saying? Do they see this as a solution to overcoming complexity and gridlock and providing better care in the long run? Or do they sort of go, yeah, it's a good idea, but I got to go back to the shop and do some work?
Right now, I'd say 85% go back to their shop and want to do more work. I think I've yet to have any fruit thrown at me, largely because we're so early in the adoption that it's the like-minded early adopters that are getting together. So we're at Health 2.0, Medicine 2.0, Doctors 2.0. These conferences pretty much go on once a month. There's some place for me to gather with people who think similar to I do, but that just helps us evolve our concepts.
So you're overcoming a history of silos and fractures, and that's going to take some time. It's not just technology. It's not. As I point out in my book, it's not technology. It's not we don't know the solutions. It's that there's something between implementing the solution and knowing what it is, and there's that gap there. And I wonder what you think that might be. What's the resistance?
Well, I like to think that we can, in this profession, we can solve it evidence-based. So once we start demonstrating in small pilot studies that engaging in these social technologies improves the quality of care that you provide, improves your patient satisfaction. There was a large debate last week at a Mayo Healthcare Social Media Conference on ROI within the medical practice about building trust and credibility within your patient population, the access you provide. I think once we start collecting that data, that this works, then the technology diffusion curve, we go back from the overhype, we go down into the utility of it. Maybe that's 2 to 3 years before it's useful to the majority of physicians on a daily basis, when it actually saves them time instead of being seen as a time sink.
And on that note, we've come to the end of our time with you, and I complained to the producers that I needed 2 or 3 hours with you because this is a complex problem, and I do think that you offer a very unique solution and an important one to get us back on the track to more universal quality in terms of our healthcare delivery. I want to thank you so much for being with us today and for the great work that you're doing. And before we leave, I just want to check in with Meredith and the folks that participated in our chat room today. Meredith, how's it going there?
So many questions we didn't get to. Thanks to Thistle, we didn't get to your question. Michelle, Alexandra, we are going to be doing some tweeting back of answers for you when we wrap up. So come back next week. Keep asking your questions.
And that wraps up this week's news, except for one last thing. A few weeks ago, I was speaking to Senator Bill Frist, who many of you might remember was a cardiothoracic surgeon prior to entering politics. Senator Frist reminded me that the hubbub about national health care programs seems to miss the point. The fact is, roughly a third of your health depends on the genetics that you inherited from your mother and father. And then after that, about 15% depends on your socioeconomic status, 5% on environmental factors. But we now know that 50 to 60% of your health depends on what you eat and how much physical activity you have. That's right. Up to 60% of what's floating around in your bloodstream and your body was put there by you, volitionally. So if you're worried about how the government's going to pay for entitlement programs like Medicaid and Medicare, you're looking at the wrong end of the problem. When you improve the health of people, you not only reduce the number of folks that will need those programs, but also the length of time in which they'll need them. Put simply, healthier adults means fewer patients, and fewer patients means less burden on society. So one way we can do our patriotic duty and lessen the burden on the next generation is to make a few changes to our diet. And after dinner tonight, get out and walk. Start walking, America. The more we walk, the more we live a healthy lifestyle, the less we need to worry about the government's ability to take care of us. With so many healthy Americans, there'll be plenty of health care to go around. And that's our insight for this week. If you happen to miss today's full interview with Dr. McGowan today, you can catch the complete episode on emPOWERme.tv sites, as well as YouTube and iTunes. We've made it easy for you to watch countermeasures at your leisure and to send links to your friends and family and help spread the word. And if you weren't able to get your question asked on air today, you can send comments to my website at RebeccaCosta.com. Each week we send one viewer an autographed copy of my book, The Watchman's Rattle, so be sure to register while you're at the site. Finally, our guest next week will be Andrea Cates, who'll be here to talk about the Business Genome Project, a system which helps companies sort, match their genome, hybridize, adapt, and thrive. Don't miss Miss Andrea Cates right here in Countermeasures next Monday at 9 a.m. Pacific on emPOWERme.tv. I'm Rebecca Costa, and I want to thank you for joining me on today's edition of Countermeasures.